Hello, everybody. Welcome back to an episode of HeartBrief. Thank you for being here. I'm Joel Kahn, medical doctor, preventive cardiologist, triple board certified university clinical professor. Let's get going. We got some really, really good papers to share with you, and hopefully you'll enjoy them as much as I did. So let's start with an analysis on a procedural technique that you may not have any patients getting in your practice, but it's available, and that's called lipid apheresis for high lipoprotein A levels. Basically, a dialysis type procedure, but the filter isn't there to dialyze kidney remnant products. The filter is there to trap and remove lipoprotein A genetic cholesterol, something affecting about 20 to 25% of all people on a genetic basis, putting them at risk for early aortic valve stenosis, calcific, as well as calcific atherosclerosis. Very difficult to treat. As of this recording, no FDA approved medication. But all over the world, LPA apheresis is used in very advanced patients with high lipoprotein A. Usually they've already had a heart attack, a bypass, a stent, a stroke, maybe even a leg amputation. Struggle to get the lipoprotein A level down. Now, this is reimbursable and FDA approved. There's limited centers that offer it, usually university centers or large hospitals, but it's worth checking out in your community, lipid apheresis for lipoprotein A. So in this paper, there was a meta-analysis of 43 publications comprising 67 studies, 2,466 participants analyzed. Lipid apheresis significantly reduced serum lipoprotein A levels. Now, that may be for a few weeks. The levels will go back up, and the treatment is an ongoing intermittent treatment, sometimes through an IV catheter, sometimes through an indwelling port, if people are going to get this over and over. Subgroup analysis confirms significant reductions across various methods of lipoprotein A detection, because there is more than one way to measure it, different disease backgrounds, different initial lipoprotein A levels. It does effectively bind lipoprotein A in the filter and lower the level. One session lipid apheresis studies, of which there were 6, also demonstrated a significant reduction in lipoprotein A after only one treatment. Therefore, lipid apheresis is effective in significantly lowering serum lipoprotein A concentrations across a group of patients and treatment modalities. These findings support the therapeutic role of lipid apheresis in managing elevated lipoprotein A. There certainly are centers, if you're watching this from the United States, that are offering this across the United States. If you go to the familial hyperlipidemia or FH website, they often list you all the centers, or just search in your area. Probably the most famous center is in Germany, where a very large number of people, like 1,500 patients in one center with elevated lipoprotein A, are being treated. So it's not the cure we're hoping for with an amazing drug that will lower lipoprotein A in events, or ultimately gene editing that will turn off the production of lipoprotein A, but it is still, nonetheless, very hopeful that we have therapies that apply. Now, in my practice, where I take care of hundreds and hundreds and hundreds of people with elevated lipoprotein A, I do not have any on LP apheresis. We do have a center, at least in Ann Arbor, Michigan. I've been able to manage them with PCSK9 inhibitors, alteration in their statin program, the general lifestyle approach, and sometimes the use of niacin. Okay, that's what I do, but I'm very aware this technique is available. All right, we're going to go to a second paper, a wake-up call for men and women, but specifically women. We just finished Heart Month, Go Red for Women. And here in the journal Circulation from the American Heart Association, forecasting the burden of cardiovascular disease and stroke in women in the United States through 2050. And it's not a very hopeful report, with the idea that the incidence of hypertension may reach close to 60% of women by 2050, that diabetes will increase to 25% of women by 2050. Obesity will increase to 61% of women by 2050. The only good news is it was predicted that elevated cholesterol will become less frequent, probably because of more effective therapies, maybe because of messaging about diet and lifestyle. Unfortunately, over time, suboptimal diet, inadequate physical activity, and smoking will decline, but inadequate sleep will increase. It's predicted, and certainly inadequate sleep is related to high blood pressure at a minimum. The prevalence of coronary artery disease going up, heart failure going up, stroke going up, atrial fibrillation going up, total cardiovascular disease and stroke going up. Even in girls 2 to 19, it's projected that there will be an increase in cardiovascular disease and obesity. So these are sobering predictions, and they should generate a tremendous response from the medical community, from the government, and the rest. Whether that'll actually happen or not is unclear, but just imagine 6 out of every 10 women having cardiovascular disease by 2050. Just the burden on the medical system, the burden on the number of specialists and generalists needed to take care of these people, plus all the consequences of the disease and the quality of life and the expense in trying to manage these problems is just, it's scary. And we got to get excited, and we got to, test, not guess, and identify people at risk and start early, start when they're teens, without a doubt. Okay, one more paper. Let's see if I can do this right. Made headlines this week, very controversial. British Journal of Cancer, 2026. Vegetarian diets and cancer risk pooled analysis of 1.8 million women and men in 9 prospective studies on 3 continents. First author, Yashvi Dunaram. And this just came out this week, generated headlines all over the place. And they basically analyzed in the United States, United Kingdom, Taiwan, and India, a series of studies that reached almost 2 million people studied that had databases that did not have cancer at baseline, had a follow-up on average 16 years later. 1.6 million were meat eaters, 57,000 were exclusively poultry eaters, 42,000 were pescatarians, 63,000 were vegetarians, and 8,800 were vegans in these cohorts. They looked at the incidence of cancer by diet. And what they found is poultry eaters compared to meat eaters had a lower risk of prostate cancer by about 7%. Pescatarians had a lower risk of colorectal cancer by 15%, breast cancer by 7%, kidney cancer by a whopping 27%. And vegetarians had a lower risk of pancreatic cancer, 21% less, breast cancer, 9% less, prostate cancer, 12% less, kidney cancer, a whopping 28% less, and multiple myeloma, also a whopping 31% lower. But vegetarians in this observational study were found to have a higher rate of esophageal squamous cell cancer. And the surprising finding in this study, with only 8,800 vegans out of 1.8 million people, was the higher rate of colorectal cancer. If you look here and you look to the left where it says colorectum and you see the line of identity, you can see there were only 93 colorectal cancers in the 8,800 vegans, but adjusted for the numbers and hazard ratios, there actually was an increase in colorectal cancer in this small group of vegans. If you look above under stomach cancer, there were so few cases in vegans, they couldn't identify a statistic. Same thing for esophageal cancer, couldn't identify a statistic, so rare. Mouth and pharynx, couldn't identify a statistic. Liver, for vegans, couldn't identify a statistic. Pancreas crossed the line of identity, no increase, but also no observed decrease. So this generated this week a lot of conversation about optimal diet. Is it the pescatarian diet? Is it the vegetarian diet? But at least, we do have data the vegetarian diet had definite advantages. Now, the data, the suggestion that there's an increased cardiovascular risk to vegans is contradicted by a number of other studies, some of which follow people up for 17 years, 20 years, studies in people with metastatic colorectal cancer put on vegan diets in actual fairly large samples that did better than those on omnivorous diets. So it's far from resolved from one single, even large observational study. I will declare my bias. I've been a vegan eater for 48 years, since I was 18 years old. I'm not changing. I like it. I like all the food. I like what I don't eat. I'm not going back. So there's my bias exposed. But I did want you to know what the science says this week on HeartBrief. We'll be back next week with 3 new studies. Hopefully, these 3 studies presented will give you some basis to consider when you see your patients, approaches, advice, and certainly heart disease in women, we must stop. There's no question about it. Thank you.